Welcome, GynoCurious listeners. I am your host, Dr. Amy Novat. We are here to investigate what it means to be a healer and to be healed. I am thrilled to ask Keri Gill to be here with me today. She is a physical therapist and the supervisor of physical medicine at Northern Duchess Hospital in Rhinebeck, New York. And she's here today to discuss her work and the phenomenon of lymphedema. Keri is well reputed in this area. She's an expert in therapeutic lymphatic drainage, helping many, many people who are suffering from this problem. But she's also an active participant in national organizations that are working to better understand this challenge. Keri, thank you for being here today.
Thank you for having me.
It's my pleasure. So I guess I'd like to ask people, how did you get into physical therapy? Why are you doing this work? You're a woman I know could do a lot of things.
Well, I think my journey as my interest really in physical therapy started early in high school and really looking for the combination of science and really exercise, sports, and the ability to really combine those two things together. Really, I think that's what drew me, the idea that a physical therapist could fix someone with their knowledge of how their body was aligned, of the use of exercise, the use of your hands to actually impact a cure and a fix on someone was really, I think, what drew me to the profession in the first place.
Were you an athlete?
I was a runner.
Did you have physical therapy treatments as a young person?
You know, certainly a little bit, and certainly a lot of friends who did as well. And I think that's really what opened my eyes to the profession, and think, oh, that's pretty neat that they're actually able to, fix you. Right.
Yeah.
Without medicine, without mysterious chemical interactions, it's really something that was, that true physical manifestation of healing.
Yeah. So when a physical therapist touches the body, can you go through kind of what are you thinking about? Are you thinking only of muscles? Are you thinking of fascia? What are the layers, if you will, of the body that you are thinking about and touching?
Yeah, I mean, I think it starts well before you touch the person, right?
Speak to me about that.
Yeah, I mean, I think it really starts with the observational analysis, right? Every physical therapist is watching how that patient walks into the exam room, how they're moving, right? It becomes that observational piece first, and then really that, interview with the patient as to what they think is going on, and then really then trying to put those pieces together, look at really how someone is moving before you really actually get to the point where you're putting your hands on. And certainly all of the things you mention are things that we're, interested in looking at. You just sort of, narrow down your focus, I think, based on what's presenting in front of you, And then I think it's important to then decide, okay, what are we looking at? Is this something in a joint? Is this something in our soft tissue? Is it a muscle? Is it, again, fascial layer, skin? Is it edema, right? Like certainly, there's lots of different things that you could really be looking for.
Is it common or uncommon that someone might walk in and say, oh, my hip is really a problem? And you're like, well, it's not your hip, it's your knee kind of thing?
Absolutely. And I think that's one of the mantras of therapy is always clear the joint above and below, right? That's like from the first days of training, you got to look beyond, because certainly the other old joke is it goes back to the knee bones connected to the thigh bone. It's sometimes not any more complicated than that, that you just have to look wider, right? How someone's walking may impact how their back is aligned and what they're getting or how they're sitting. So much of that is interconnected and you have to look for that first.
The mechanics of living. Yeah.
Yeah. And especially in a modern society where we sit excessively.
Far too much. I like to remind people that there's science now that shows that when we sit, for 8 hours a day in front of a computer, the health risks are likened to smoking.
Yeah.
And we do it. I mean, I don't know about you, but I'll find myself working at my computer and all of a sudden 2-3 hours have passed and I'm not even aware I have not moved a muscle except for my fingers. Right?
Yeah. Oh, absolutely. I think, my movement into some management level stuff has exposed me more to, what desk work is, being a practicing therapist my whole career, right? I'm standing working on people. It's a different kind of fatigue that you're experiencing. But the idea of saying, okay, I'm actually having an office day today and not treating any patients, it's a different level of fatigue and feeling like garbage, right?
Yeah.
Like, for sure. So I have great empathy for those who have work that requires them to be seated for a 40-hour work week. It's a challenge, right? It's a big challenge to figure out how to make it all work and keep your body healthy at the same time.
So just, I guess, briefly, what would you say to those people who are seated for 40 hours a week? What can they do to just make sure that it is, well, to improve their quality of life given that work?
Yeah, I mean, I know the cues I give myself are hydrate, because I'm good at sitting there for 4 hours and realizing I haven't had a sip to drink in that time. And then I think the other big thing is trying to take those breaks, right? You really just say, okay, at least once an hour I'm standing up, I'm going to get something off the copier. Maybe I'm not looking at being the most efficient in my work as possible, but I'm actually trying to balance the fact that I can move and go do those things instead of queuing up 10 print jobs and waiting 3 hours to print them. Maybe go get them as you do. And it's also a good, healthy mental break, I think, at the same time, right? It's important to have that interruption. And then it's also like, go take that walk at lunch, right? There's the go outside, breathe some fresh air, move a little bit. You just have to, we talk about motion is lotion is sort of, another favorite physical therapist mantra, and it's really, you have to impart that on the body, right? You have to introduce that somewhere along the line. And even if it's small, you have to make those interruptions.
Right. People will often say to me, oh, but Amy, I can't, I only have 10 minutes for lunch. And I'm like, 10 minutes is 10 minits. It's better than none.
Eat and walk, right? You can kind of do that kind of thing too, I think.
Yeah.
It's super important because it's just, like you said, the health impacts are big.
Yeah, exactly. So I suspect there are people out there who are saying, why is Amy talking to Keri, who's a physical therapist, who's going to talk about the lymphatic system? So I guess let's start with, what is the lymphatic system?
Yeah, so the lymphatic system is a fluid movement system, really, right? It's part of our circulatory system. It's probably the least talked about or understood system in the body, and probably one of the most important, right? Because it also has really important immune system functions. So the way I describe it to my patients is, if we think about sort of a water treatment system, right? The fluid from our tissue, which would be at my house, goes through a whole bunch of sewer pipes, basically. It goes to the lymph nodes, which are the water treatment centers. It filters out all of the toxins and other materials in our body, and then it returns that clean fluid to the venous system. So it just, again, we're made mostly of water. Everybody has sort of heard that. This is just a huge part of how fluid actually moves through our body that no one ever bothered to talk to you about.
Is this system, this vascular system, really superficial? Is it really deep inside? Do we have access to it ourselves? Or do you have to be a professional like you to kind of know where it is?
It's everywhere, right? So it's all of the above, right? So much like you think of the blood, right? And the vascular system with the blood, we have small vessels that lead to larger and deeper vessels. The lymph system is sort of the same way. There is very superficial vessels that then lead to deeper and deeper vessels in the body. As a therapist, what we focus on primarily, because I have access to, is the superficial system, right? And that's where our techniques and treatments are often, focused. As a human being, we have access to our lymphatic system through exercise, motion. There's a reason why your legs swell when we sit, Some of it's about gravity, but it's also about encouraging the muscle pump and movement that happens and passively moves fluid by impacting the way our skin is stretched and pulled, by the way our muscles contract. And then also even through breathing, like we have access to that, autonomic nervous system in that way. And we know that working on deep diaphragmatic breathing actually will impact the rhythm of the lymphatic system.
Breathing, people, breathing. We do it automatically, but we do it unconsciously in a way that should be more conscious, taking deep breaths.
Yeah, and I think it's, we know that breath work, right, in every system that you look at of generalized health is important. And this is just one of the other systems that it impacts. I think it impacts so many things that you really can actually help to regulate. That system, the lymphatic system, is not driven by a central pump, right? We're used to thinking of our heart pumping and moving fluid through our system. The lymphatic system vessels are more like a line of sausages, links all lined up, right? And they have smooth muscle and they contract and they propulse the fluid as they move. And so anything that you can do that actually impacts the system that way can assist in the movement of fluid in that superficial system, because it's just below the skin, so we can access it pretty easily.
Yeah. So I want to move into lymphedema, but I have a question for you. So I go to the local movie theater upstate, and they make really good popcorn. And I salt it, and I put nutritional yeast on it, and I eat a whole big bucket of it. I just love it. It's my favorite snack. The next day, I wake up and I can't take my rings off, and my feet feel a little swollen. And I think, oh, I got to stop eating so much popcorn when I go to the movies, which I've not yet done. But is that lymphedema? What is that? Because I think we all have the experience of eating too much salt. As we shift, what is that? And help us understand this.
Yeah, so I think what you're talking about is sort of fluid retention, right?
Mm-hmm.
And that's a general retention of fluid in the body. That is not lymphedema. I'm going to give you the example I give to my patients all the time. And if any of them are listening, they're rolling their eyes because no one wants to hear it anymore. But I always talk about what edema is, which is just generalized fluid and swelling, the difference between edema and lymphedema. And they are very different, right? So if we think about our little rowboat sitting in the ocean, right? In a normal intact system, the boat is dry, our fluid is moving where it needs to be, everybody's where they're supposed to be. Then we have things that happen to us, like I eat a ton of sodium, I sprain my ankle. I like the ankle sprain because that's a nice, simple one without lots of other systemic challenges.
Mm-hmm.
But if I sprain my ankle, I get this large inflammatory event that happens, right? We expect ourselves, I sprain my ankle, I'm going to swell, right? That's not surprising to any of us.
In fact, it's normal and needed.
Correct. That's how we heal, right? So that's sort of like my little boat in the ocean, and a storm comes upon us and it dumps a ton of fluid in my boat, right? And so over time, the storm's going to stop, right? The inflammation's going to stop. I'm going to stop hurting myself, and the system's going to heal. The air's going to evaporate, right? All that water in my boat's gone, and things go back to normal, right? That's the normal experience most people have with swelling in their lives. When we start talking about lymphedema, I kind of give the explanation of, well, that storm comes up, and sometimes it damages the boat, right? And so now the sun comes back out, and I still have a fluid problem, right? And I'm going to have a fluid problem long term because the anatomy is now, damaged or dysfunctional in some way that it's not able to move fluid at a normal rate. So the issue is no longer that there's too much fluid in a temporary system. It's that I now have the inability to move fluid that I need to stay alive, my normal sort of what we call physiologic needs. I can't move that much fluid anymore. And as a result, that area of my body has swelling. That is what we call lymphedema.
And what are the more common causes of lymphedema? Why does someone have this chronic storm or the break in the boat?
Yeah, so a number of things. So probably the most common in the United States would be cancer treatments, right? As we go about treating cancer, the lymph system is sort of the way cancer can move and progress. And so treatments for cancer are focused on, sampling lymph nodes in surgery, doing radiation. All of those things can create, a deficiency in the system that then causes a regional problem in that area. You can also have lymphedema because of, repeated infections, venous problems, circulation problems that sort of occur. And obesity is actually another major driver of lymphedema in the population that we see.
Can you explain that one?
Yeah, I mean, partly it's a combination of things, right? Fat is known to be very inflammatory and creates more fluid load. And it's also a function of how much tissue that someone has in terms of their soft tissue that the system has to impact. There's also thought that because as you develop more lobular fat, you're further away from your muscles, you're less able to create pumping against that tissue, and fluid sort of sits there more stagnantly. And as a result, essentially you build up fluid, and then that creates a failure over time.
So I would imagine, using the boat analogy, that people can have mild problems with the boat, moderate, that there's this range of lymphedema. If someone gets So I guess, yes, is that correct?
Absolutely.
So also if you get, let's just say you're diagnosed with mild lymphedema, does that mean you have mild lymphedema forever? Or is there a possibility that these shift and change over time?
That's a good question, and a somewhat loaded one, right? So the real answer is probably once you have it, you sort of have it. We talk about lymphedema really being in sort of, 3 stages, right? And there's sort of a latency stage that we start with. And that may be, someone has had lymph nodes removed, they have had radiation, they're sort of in an at-risk group. We know we've created damage to the system. The system's really robust, though. So just because we create some sort of damage to it does not mean I'm actually going to manifest and see swelling. That patient may go the rest of their life just fine. In many ways, it probably goes back to genetics and how robust your system was in the first place. In the other reasons why we have lymphedema, genetics is actually one of them too, right? People can have something called primary lymphedema, which is a hereditary form of lymphedema as well. So
So no surgery, no treatments, no obvious injury, just genes are dictating this.
Absolutely.
Interesting.
And so you can see the current thinking is now when we talk about secondary lymphedema, which would be the result of cancer, traumas, etc., that is really potentially an unmasking of a genetic predisposition towards developing this condition that maybe would have never manifested unless we had the additional trauma on top of it. And so that goes a lot in terms of what we talk about in terms of prevention for patients and how much is possible to prevent, how much is not possible to prevent. And also potentially how severe their swelling gets is probably based on that. I liken it to telling patients that you started with a bank account, essentially, of lymphatic movement. I have, and some people were born with really big bank accounts, and we start making withdrawals when we have trauma and we have issues. And, other people, unfortunately, started with a genetically smaller bank account, and that same type of withdrawal can result in a much different outcome than for someone else.
Yeah. That's helpful. That's really helpful. What does it look like? What does it feel like? So if somebody's out there thinking, gosh, maybe this is going on in my arm or my leg and my doctor doesn't think so, but I kind of think something feels different. What would you say to them?
Yeah, I mean, I think the biggest thing that we know is that treating lymphedema early results in the best outcome for patients because we can really arrest something. So as I was talking before, that stage 0, things that are at risk, that patient may experience heaviness, fullness, rings not fitting right, kind of your popcorn story, those same things, but generally they're in a region, So say, for example, I think that's the other big piece. People ask me all the time, like, oh, I've had breast cancer, on my left side, so the place we would consider at risk would really be your left arm, right? So we're kind of cut into quadrants. And so we have axillary lymph nodes, which are in your armpit, and they drain your trunk in each quadrant, and then they also drain the extremity attached to that side. And we also have the same thing in the groin. Those inguinal lymph nodes sort of drain each of the legs. So when we see damage, it's usually in a specific area. So we're talking about a very specific regional type of swelling rather than systemic swelling like your popcorn story where all of my limbs are feeling puffy. So the question is that limb feeling different? Is it feeling heavier? It feels fuller? Is it different after I'm exercising or putting some other, load to that limb? If that's the case, we really want to have people sort of seek treatment earlier rather than later because we know that if we intervene sort of in that prophylactic sort of phase, we could potentially prevent chronic nature of swelling from really developing over time. And even if we can't, it would be in a much earlier stage. So an earlier stage lymphedema, like a stage 1 lymphedema, would look like the swelling comes and it goes. It waxes and it wanes, Oh, my leg is kind of swollen when I'm awake and then I go to bed and it's better. So I don't think that there's anything wrong. But really, that is not normal behavior for our body. And we really should be having that looked at, whether it's lymphedema or another type of disease process. Right, that's something that we really should be managing more closely. Unfortunately, what would happen then is patients would not present for care until they hit like that second stage, which is, well, I used to go to bed, the swelling would go away, but now I wake up and I'm just as swollen almost as I was when I went to bed, right? And then there's the stage 3, which are the Google pictures, which is really what we call stage 3 is lymphedema elephantiasis. we don't typically see that a lot in the United States. It's really endemic in places like India, South America. There's an infectious disease called filariasis that sort of causes damage to the lymphatic system. And unfortunately, those patients do not usually have access to medical care. And unfortunately, that's left to its own devices for potentially decades at a time. So unfortunately, those limbs are incredibly large, swollen. They get skin changes. For the most part, again, that's not the typical course of what we're going to see in the United States. And I tell my patients that it's always good, the scared straight photos of I'm going to do whatever you say. But the reality is it's very unlikely they'd end up in that place anyway. And I say, why? Because we're here now and we're addressing it now. And I think it's really about having a patient be empowered to say, this doesn't feel right. And that's good. We want you to come back and report that to us.
Right. So let's pivot to treatments. So somebody says, my leg feels a little bit different. And my doctor, I had pelvic surgery. And so maybe it is this lymphedema phenomenon. I'm not sure. What are the steps that people should take? And two, what are the treatments that you do?
Yeah. So I would say in the cancer population, those patients get to me in very early stages. And it's because the physicians managing those patients are very aware of lymphedema as a side effect of what's going on. So those patients are getting referred in that I don't feel quite right phase. We're managing them super early.
Would you recommend they come even before their surgery?
In many cases, we do see people before.
Yeah,
right?
Interesting.
And really educate, as part of, post-operative range of motion, exercise education, say post-breast cancer patients, things like that, right? And really, I like to use that as an opportunity to really empower patients as to, to say, if it doesn't feel right, know that that's okay. Trust your instincts. We believe you. It's not a bother. The physician isn't going to look at you like, you shouldn't have come and told me this. You're wasting my time. This is important, and it's important that we deal with it. I always tell patients, I'd rather overtreat something in terms of an edema than undertreat it, because the potential long-term consequences of us missing that early are much worse for the patient, right?
Yeah.
So unfortunately, non-oncological, so non-cancer related versions of lymphedema often come in a much later stage to us, unfortunately. It's not one of those things there's many other causes of lower extremity swelling. It's typically lower extremities in those cases. And I think it's harder for that to get sussed out to figure out what the correct diagnosis is and to get people in the correct treatment.
Yeah. So when someone comes to see you, what do you do?
Yeah. So when they come to see us, basically what we do is I do a physical therapy evaluation. So we look at how they're moving. We look at how things are aligned. And then we really assess what's going on in terms of swelling. We look at measurements. We try to assess really how much swelling is there. And then how much has this swelling then impacted their skin, right? Because we know that over time, swelling that sits chronically in the tissue creates fat that gets put down, and it also creates something called fibrosis, which is really scar tissue. So over time, we start to see thickening of the tissue and the skin. So we're really going to assess that to try and really understand where is the patient in terms of their progression of care. And then we're going to make a plan for how to sort of manage it, right? And really what the gold standard for management of lymphedema is something called complete decongestive therapy, which involves a couple of different modalities. So one is something called manual lymphatic drainage, which is a type of massage. That's a very superficial massage that we do to stretch the skin, to force the fluid to kind of move through those little vessels and kind of get out of the area that's congested. So I refer to these as the bailing water, right? Back to my boat. That's why everyone hates the boat. Comes back constantly, right? So these are our bailing water strategies. The system's not moving fluid fast enough. I'm going to move it faster for it, right? So exercise also fits into those categories too, right? Being able to exercise often with compression, which we'll talk about in just a second, but that will enhance the movement of fluid out of the area. There are also things like machines, which are called pneumatic compression pumps. And so they inflate. They're an external pump that does exactly what you'd think. Looks like a multi-layered blood pressure cuff that will move fluid along the limb for us. The problem with all of the bailing water techniques is you can't do it all the time, right? You have to go on about your life.
Right.
And so the big question is always, if you're in a boat that's got water in it and you can't bail water, what else are you going to do? We're going to patch the hole,
Yeah.
right? And that's what we use compression for. So compression comes in a lot of different ways. People are probably familiar with compression stockings and things like that, socks that they'd wear. We have various things for various body parts, pretty much all of which can get lymphedema. So either a compression sleeve, compression stockings. It depends on how far and where the fluid really is in terms of what we're going to do for compression.
I'm going to interrupt you for a second. Are these the things that you see professional athletes like wearing on maybe one limb or another? Is it for that purpose?
They can be so certainly a lot of what we've used has been that we use medically has been sort of taken over into the sports and performance market as well. Making sure that it's a medical grade device that has the right amount of compression. Lymphedema is a disease and we need to treat it as a medical process. That's not to say that you can't get some benefit from something that's just an off the shelf, but we really want to be precise in the level of compression that we're using for patients. Compression can be dangerous. And so you want to really make sure you have somebody that's guiding you through that process if you do have a problem rather than you're just using it for a support sock or...
Right. So compression and constriction are two very different things.
Well, compression can lead to constriction, which is a big problem if you already have a backlog in fluid in an area. There are also a lot of other types of devices that we use. This is my public service announcement that if you're really swollen, you do not want to put a stocking on, right? A stocking, a sleeve, compression, elastic compression is designed to maintain. Right. So typically we think, oh, okay, my doctor asked me to put these compression socks on, put them on first thing in the morning when I'm not swollen. And then they stop me from swelling throughout the day. With my lymphedema patients, if they have progressed into a later stage and they're already swollen in the morning, as we talked about, putting that stocking on is going to be incredibly painful. That elasticity is going to force that to squeeze into their tissue. They're going to feel like that overstuffed sausage casing and they're going to rip it off. And they're, that's probably, I hear that in that initial visit with patients. I've already tried that. It didn't work for me. And you go, it's the right thing, but we're going to do something else. We have to do something compression wise that's less elastic. That's more like, I always say, it's more like a cast almost, the way it's going to envelop your limb. It may be neoprene or something like that that's able then to shrink the limb down. So we go through, progressively shrinking the limb till it's at a stable side, and then we'll go use that stocking. So it's the right thing, just wrong timing a lot of times.
Interesting. Do people ever have surgery for this problem?
Yeah, so that's a huge emerging area of research at this point in time. I think, it's getting better, I think, in terms of what they're able to do and offer. So part of the challenges historically has been the lymphatic system. When we're talking about those little vessels, they are, millimeters in size. They're tiny. So one, you've had to have microsurgical techniques get to that level where they can actually put vessels back together, not scar over, and have them sort of work. So they're kind of our two major things that are being done right now. One of which involves taking lymph nodes from another area of your body and transplanting them in the area. So say it was a breast cancer and they took out some of your axillary lymph nodes, they would potentially take out lymph nodes from, usually it's like the omentum that they tend to do, which is the area like by the stomach. So they're deeper vessels. So we're not causing lymphedema in another part by taking those vessels, right? Moving them to that area and then really having things sort of grow and have, basically there's a process called angiogenesis where like attracts like, and basically the vessels will seek their way to those new lymph nodes and create new pathways. That can be very successful in some patients and not particularly successful in other patients. And so I think they continue to try and figure out why. The question is why. There's so much of that genetic issues and challenges to understand why is this successful and why this isn't. The other major version of surgery that we're seeing a lot of now is what they call a lymphovenous bypass, which is basically taking those lymph vessels and plugging them into a vein. So they find ones that work and they basically plug it to a vein. So now it doesn't have to go through the whole lymph system to get back to the vein. You're creating a bypass, right? You're basically creating another road that it can take to drain the fluid out of that area. The exciting thing that we're really starting to see, and there's some really good research coming out, is doing that bypass surgery at the time someone has a mastectomy, right, can really potentially reduce the risk of somebody developing lymphedema. There's a couple studies going on right now that some of the early data has come out that look very promising. So it's encouraging to see kind of where this is going to be down the line, that they can, offer this to patients and again reduce their risk further of potentially developing
Oh,
this.
that's so exciting. So it certainly sounds like these surgical interventions are, they're not universally available. They're being done in very specialized centers. Again, it's something that someone listening out there might ask their doctors about.
Absolutely.
They may certainly be eligible, but don't be frustrated if in the middle of Rhiniecliff, New York, where we're taping here, there isn't a vascular person to do this. You'd have to probably go into New York City.
Yeah, I mean, we are seeing certainly, even locally, some of these bypasses being done with the mastectomy, certainly. I think the big issue is what, if you're having it done prophylactically, you're having surgery anyway. To me, that makes tons of sense. Like, good. It's not going to take that much longer. They can offer this. There's not a lot of other risk. I think the question becomes, once I've had lymphedema, it does seem like these are better in the early phases, and it's likely because the further you get in the process of lymphedema, the more anatomical changes you have that you probably can't quite undo, right? And so early is better. So certainly I encourage patients to go ask the questions, find out, am I a candidate? Is this something I want to do? Unfortunately, if you look at the outcomes of the studies of people who have lymphedema, if I have this surgery done, does this mean I don't have to use compression anymore? Because that is the major burden of care that people feel with lymphedema, is the need to wear a compression, sleeve potentially all the time, right? And the goal is really to say, could I get away from doing that? Because then sign me up, right? Unfortunately, it's not necessarily that successful saying, okay, we can eliminate it. We might be able to reduce it. In some patients, you can certainly eliminate it, but it's not necessarily a guarantee that that's going to go away. So I think that often gives patients, some pause once they learn a little bit more about the surgery as to whether they're willing to go. Oftentimes these are cancer patients who have just gone through multiple years of medical treatments and are just saying, I can't handle dealing with this right now. But I think it's really important that people know that these are out there and go on their own journey and explore what's going to work for them.
Yeah, yeah. Yeah, it so reminds me, I have patients who say to me, I just want to rip these things off at the end of my day. It's kind of like the storyline of so many women who wear bras all day long, or compression stockings. Remember the days in the 80s where everyone was wearing stockings and they had those compression tops and they were miserable, absolutely miserable. So, with great compassion, Keri and I understand how difficult these compression techniques are. So just to reiterate, so there's the manual drainage that someone like a physical therapist does, but not all PTs know how to do this, right?
No. So certainly you should really seek a therapist that has a certification in lymphedema management. That means that sort of guarantees they've had advanced training in this specific area. And for the most part is probably their focus of their practice in terms of managing this type of clients.
Okay. So the manual drainage, the compression stockings or sleeves, talking to your doctor about whether surgery is even an option for you. Is there anything else that we should be mentioning? I mean, what about diet? What about, it sounds like exercise is something we'd want to add to that formula.
Absolutely.
Yeah.
Yeah. Diet, I think, diet for the most part, there is no magical real diet for lymphedema, right? I think the biggest piece is that, certainly if you're someone who is sensitive to sodium and retains fluid around sodium, that isn't a hallmark of lymphedema, right? But you're living in your own body that may have these other issues. So if I eat popcorn and I swell a lot and I happen to have lymphedema, it's probably going to make my lymphedema worse too, right? Right? It's that kind of idea. But just because eating the sodium doesn't necessarily mean that that's going to make that worse. But a lot of times those two things are somewhat intertwined, shall we say. I think, maintaining a healthy body weight is really important. So we know that, people who have BMIs over 30, that are considered obese, have a much higher risk of developing lymphedema. And they tend to have worse lymphedema outcomes than those that are at a lower BMI. So healthy diet, healthy body weight, managing against salt if you're sensitive to it. I think all that's very important. There's a lot of research going on looking at anti-inflammatory diets and what that all has to do. So I think, there will be more to come in terms of specifics that matter. But I think the biggest thing is to just try and something that works for you and work with somebody who can help you, manage your diet, if that's sort of a challenge. Exercise is by far, I think, the biggest thing. Movement. It really, really makes a big difference in terms of what's happening. We talked at the beginning about sitting at a desk all day. Well, if you have a swelling problem in your leg and you're sitting at a desk all day, it's going to be exacerbated so much more so. So the ability to just get your body to move. The other major thing that we talk about is really about good skin care. So patients who have lymphedema, really your skin is your barrier to the outside world. It really keeps infections away, right? So if I have cuts, I always likened it to, well, if I have fluid that's stagnant in an area, it's sort of like a pool filter that's not running, right? That water can get kind of gross pretty quick. And so, if my system is not filtering out bacteria as rapidly, my risk of developing an infection in that area is potentially a little bit greater. And so, that doesn't mean we want to go crazy and, put bubble wrap around our limb and not engage in life. It just means, like, if I get a cut, I should probably wash my hand with soap and water and maybe put a Band-Aid on it, right? The basic ideas, and then watch it and go, if this starts to look kind of funny, maybe I should seek medical care instead of ignoring it for 3 more days, right? It's like the very basic structures of trying to take care of ourselves. So skin and nail care also becomes very important. Use of moisturizer, stopping the skin from cracking, especially in times like winter and things like that, because again, it just opens us up to a potential of infection.
I really appreciate that you brought that into the conversation because, again, self-care is being discussed on GynoCurious a lot, and it's from a lot of different perspectives. And we haven't yet talked about skin on GynoCurious, which reminds me it should be a podcast, episode. So thank you for sharing that. And I would say to everyone out there, even if you don't have lymphedema, skin care is so important. As we like to say, it's the largest organ in the body. It has a lot of functions and importance to our overall well-being and health.
Absolutely.
Yeah. Is there anything else that you would like people to know about your work, lymphedema, how to access the resource? Anything you think people should know?
Yeah, I think the single biggest thing is that if somebody is at risk, right, that for developing lymphedema, that it really is about trusting your instincts, asking the questions, making the push, and asking. And I think there's a fear of, I don't want to bother the physician. I don't want to go bother the office and make this call. They're busy. This isn't that important. But I think what you're going to find on the other end is physicians are very receptive. This has changed very much in my 20-something years of practice in that, it's not bad enough to deal with yet, right? That was the beginning of my practice time. Now it's, oh my God, we got to get you. We're going to medically screen you, make sure that there's nothing else acute going on, and then we're going to make a referral to somebody who's appropriate to manage that, So, yeah, and I think there are a number of lymphedema therapists here in the Hudson Valley that people can access. Certainly, I work for Nuvance Health. We have therapists up and down the entirety of the system, so hopefully somebody's geographically close to you that really can help you with this type of problem.
Great. Do you continue to be an athlete?
I run.
Oh,
Absolutely.
Okay. And it gives you pleasure and joy and takes you out of your office?
It does. It's a very good stress management technique.
Yeah,
absolutely.
Good. So all of you listeners, please, we want you to know about this problem. There's a reason I asked Keri to come today. It's a problem that people don't talk much about. And unfortunately, because breast cancer, pelvic cancers, these are all, more and more common. And of course, there's so many other reasons that lymphedema can occur. I just thought it really important to bring it out to the public forum. Attached to the episode, when this is dropped, there's going to be some information that Keri will supply, everything from how to resource her and the national organizations around lymphedema. Please, if you have questions or concerns, please let us know. Write to comments@radiofreerhiniecliff.org or GynoCurious@gmail.com. If you want to reach Keri, again, I will provide you that information. Don't hesitate to reach out to us. Remember, subtle changes are exactly when you want to get in touch with someone like Keri. Thank you so much for joining us today, Keri.
Thank you so much for having me.
And thank you to Jan Hammoud and Matty Rosenberg, the producers of the show. And thank you to the Epicurean for having us here for Radio Free Rhiniecliff and creating a home for us. Until next time, please stay well and listen to your intuitions and instincts. They are the greatest of teachers, not to be ignored.